Pam, I found that table you were talking about, 66.9. Professional care in the shock chapter.
I know, I'm sorry. I had bumped ahead to ARDS in 68.
Cool.
Oh, gotcha. Yeah, about the trauma.
Mine is in this book, it's all the different shocks, and then the drug therapies and the supportive therapies. I thought that was the index we were talking about.
I must have misunderstood you, Di. You said 67.9, correct?
I said 66.9, but remember, you've got the old book right now.
Yeah, so mine is a different chapter.
That's cool. That's fine. Because I think a lot of the students have the older edition.
So maybe that'll help if
Yeah, we'll see.
you give one. So the title is Emergency Management.
No, it's this, Pam.
I'm sorry.
No, it's good. It's this.
Oh, gotcha.
In the shock one, the one you were talking about before. Okay.
Hi, so the students that just came into the meeting, can you guys please put your name and your student number in the chat and send it to me privately? That'd be wonderful.
Welcome, everybody. It's so great to see all your beautiful faces. You may recognize this beautiful face up here next to me. That's Pam Markford, one of my very best friends. Her and I actually graduated from this program together in 1982 with Florence Nightingale. Anyway.
I can bring the picture if you want me to, Di.
Anyway, so she retired before I retired, and now we're both back doing this because we love you guys and we think this is lots of fun. And we want to help you understand all this material. So Eleni is going to be our host. She's going to field all your questions. So in the chat, if you, first of all, like Eleni asked, please put your name and your student ID, send that to her, and then send her your questions. And then as this gets going, if you want to talk to me, that's totally cool. Just raise your hand, unmute, and we'll chit chat, you know, because I see some faces, I see mainly names and such. So it's hard for me to gauge whether I've helped you understand the content or what have you. So don't worry, we're not in a rush here. We're not going to leave until everybody feels good about stuff, okay? So Eleni, have you gotten some questions yet?
No, I don't have any questions yet.
No questions? Yikes. All right, guys, this is the question and answer period. You should have already went and watched the video. The shock video, and we're happy to review anything. I think what we'll do is, while we're waiting for people to come up with some questions, since this is the trauma shock workshop, we will start off with remembering the different 5-level emergency severity index, the ESI codes. And I went over it at the end of the workshop, and it's just, I'm going to give you a mnemonic to help you remember this, okay? And then I wouldn't spend a whole lot of time here, but it is helpful to know. You want to definitely make sure that you know your A, B, C, D, E, F of trauma, which is, you know, airway. Alertness is A, B is breathing, C is circulation, D, disability, E, exposure and environmental control, F, facilitate adjuncts and family. Make sure you go through that. And then as far as the ESI scale, I always tell students ES1, that's your most critical patient, right? ES1 gotta run. They're very unstable. They need to be seen immediately. There's going to be high resources. This is usually somebody who's already in cardiac arrest. They've been intubated. They're a trauma patient, severe respiratory distress, something to that effect. So ES1, you got to run. You need to see them immediately. ES2, I always say prevent code blue. ES2, prevent code blue. So this patient's in a threatened state. Likely, but not always obvious. You need to see them within like 10 minutes. There again, they're going to need high resources. frequent consultations, continuous monitoring. This person is like somebody that has chest pain from ischemia, multiple trauma. By the way, I'm looking at page 1606 in the newest edition, which is the 10th edition, 11th edition, the red book. But you can find it in your old book. It's no big deal.
Di, I have
Yes.
a student that says the MODS, ARDS, DIC, etc. video cannot be viewed.
Oh, no.
Yeah. Did you all get to see it? Did other people see it?
I saw it.
Yeah, I don't
You might-
understand.
Another
You might
student
have to like copy and paste the link. Sometimes that works.
Brenda said maybe copy and paste the link and sometimes try another browser and make sure that your pop-up blockers are off. That would be helpful. Here's the other thing, guys. You can go back into the NIP Commons, and my earlier Shock, ARD, SIRS, MODS ones are in there as well. But you should be able to view it because everybody was viewing it. That doesn't mean that people don't have issues, but I'm sorry about that. Okay, so ES1 got to run. ES2, prevent code blue. ES3, you can wait and see. ES3, I can wait and see. That's usually up to an hour, okay? Medium to high resources, this might be somebody that has a abdominal pain or a gynecological disorder. They're probably going to need a lot of tests, okay? ES3, I can wait and see, maybe up to an hour. ES4, they walked in the door. ES4, they walked in the door. Nothing's life-threatening. We can delay seeing them. Low resource, low intensity, possibly like a simple laceration or a cystitis kind of thing. And then ES5, jive. ES5, it's jive. I don't even know why they came to the ER. Could be somebody, this could definitely be delayed. It's low resource, low intensity. Maybe they have cold symptoms. They need a wound recheck, something to that effect, okay? So those are your 5-level emergency severity ESI.
We have a student that's wondering if you can go over ventilator settings and what they need to focus on in terms of that.
Okay, well, why don't we do this? Let's go through, let's
Just
go,
make a note. Okay.
yeah, ventilator settings. Let's find that in the book.
There's also a handout on ventilator settings too, Di, from NIP.
Right. And let's see if we can pull that up. Well, let me get into ventilator settings in the book here. Obviously, that you guys are going to be talking about somebody who is in ARDS. That's what this test is all about, acute respiratory distress syndrome. So this person had SIRS. They had some kind of shock, prolonged low perfusion state, and they went from SIRS into ARDS. And if there's more than one system that's going down, now they are in MODS. Okay, here's the ventilator bundle, $15.99. Let me search my, let me get here, $15.99. Okay. 89, yeah, this is the chapter.
And that's chapter 66 in the old version, like page 1616. It talks about suctioning. It talks about oral care
Yeah.
for the ventilator. And the table on page 1619, guys, is your settings for mechanical ventilation. Your rate, your tidal volume. Is that what?
So let's go here. Let me find what table is it, Pam? It's because I'm in the acute respiratory distress syndrome. I'm trying to find the ventilator stuff specifically.
It's in the nursing care and the critical care setting, Di, whatever that chapter is for you.
Okay.
In the old book, it's chapter 66. And for you guys that have the last edition, it's page 1619, table 6610, settings of mechanical ventilation.
Okay, so I'm just going to go through with it here. Respiratory common causes, hyperacute respiratory failure, chronic. Okay, so remember, I'm going to pull up my, I'm going to share my screen. I'm going to pull up the whiteboard here for a second, and let's go over this. So remember, Remember that for every 1 unit of ventilation, we should have 1 unit of perfusion, okay? So remember what's happening in ARDS, right? Our capillary is becoming very leaky, and all the fluid is going into the interstitial space, and then eventually it's going into the alveoli. Several things with this occurring that are bad include hypoxemia, because if I have fluid, I can't have diffusion of oxygen onto the hemoglobin cell and CO2 back. The other thing is that fluid is going to wash out surfactant, and my alveoli are going to collapse on themselves, okay? You still might be having perfusion by there, but it's wasted blood flow because I can't get oxygen to a deflated balloon alveoli. So when you have to go on a vent, okay, what you have to decide is a tidal volume. A tidal volume is just how much volume is going to get in and out in one breath, okay? And usually when somebody has ARDS, we use low tidal volumes because we don't want to cause barotrauma, trauma to the actual lung parenchyma, okay? We're going to set a mode. I wouldn't worry too much about the different modes. There's assist control, where we set a rate, say, of 12. And if the tidal volume is 600 mils, then in an assist control, the person can breathe however many times they want. The vet is going to make sure they at least get 12 breaths a minute. And any breath that that patient takes, it will assist them to get to that 600 mils tidal volume, okay? There's the control mode. If I'm in a control mode, that means the patient can't do anything. The patient cannot breathe on their own. And so that person is paralyzed and they are sedated, and that's rarely one that we use. There's also just the thing called pressure control, okay? Pressure control ventilator, where we will set a pressure. And as the ventilator starts to give that tidal volume, if that pressure is exceeded, it will stop, okay? One of the things that we have found with evidence-based practice is now that we will give lower volumes and more rapid breaths, okay? You've heard of oscillating ventilators, where the ventilator may be given 200 breaths a minute, kind of like going quick breaths, low volume, because we don't want to cause trauma to the already traumatized alveoli, okay? So the mode, the rate, pressure control. Pressure support, okay, is just giving that person some support. For instance, if I want to drink my tea, okay, if I just stick the end of the straw at the top of the tea, I would have to suck really, really hard. But if I push that straw down, that positive pressure is pushing that fluid up, so all I have to go, I did not have to suck very hard in order to get the tea. Kind of the same thing with pressure support. They push pressure into the vent circuit, so when the patient goes to take a breath, it's not hard to do, okay? That's pressure support, very much like CPAP, continuous positive airway pressure, all right? Now, you need to know about this function called PEEP, positive end expiratory pressure. It's going to be set between 5 and 10 centimeters, no higher than 20 centimeters of water pressure. So if positive airway pressure is blowing air into the lungs, remember you have this whole circuit. You have the ET tube hooked up to tubing to the ventilator. All of that space from the ventilator down into the lungs is dead space. The only place where gas exchange is happening is actually in the alveoli. So pressure support is helping push that oxygenated air down there so that person does not have to work hard to get the oxygen. Now what happens, and I showed you these atelectic alveoli, that's what happens in ARDS, okay? And remember, what you're gonna see in ARDS is whiteout. You're going to have diffuse infiltrates throughout both lungs, and they're going to become very stiff and non-compliant. So what we'll do is we'll put like PEEP, and it's called positive end expiratory pressure, on the ventilator setting. So they'll be getting the tidal volume as they inhale, and then guys, as you exhale, your alveoli tend to kind of collapse anyway. But what PEEP does, and by the way, if you have already had ARDS, they're really going to collapse. So what PEEP does is, as you inhale, as you're exhaling, at the end of exhalation, the vent's going to go and push a positive pressure at the end of your expiration to blow open and hold open those alveoli to increase oxygen getting onto the hemoglobin and CO2 getting off, okay? It also helps push some of that fluid that has migrated into the alveoli back out. Now, there are complications to PEEP, and you better know them. Think about this. If I'm pushing positive airway down into this alveoli, it's going to get bigger and bigger, and it may just pop, okay, causing a pneumothorax. So that is that's a possible complication, as well as then a tension pneumothorax, okay? The other thing that PEEP does, if you think about it, here's the heart, here's the superior vena cava, here's the inferior vena cava, and your lungs are on both sides. If I start increasing the pressure into my lungs, that pressure, intrathoracic pressure, is going to increase. Now it's going to put pressure against my inferior vena cava and my superior vena cava, and that's going to decrease the blood that's returning to my heart, which is going to decrease preload, decrease stroke volume, decrease cardiac output. So we may have to make up for that. So I want you to know what the good things are about PEEP. If some of these ARDS, guarantee you they are going to need PEEP. By the way, the hallmark sign of ARDS, acute respiratory distress syndrome, is someone whose PaO2, we cannot get higher than 60 millimeters of mercury. Remember, the normal is 80 to 100. While we have them on a vent and we're giving them 60% or higher FiO2. So if somebody's PaO2 is less than 60, while they're getting an FiO2 of 60, that is a hallmark sign of ARDS, okay? Plus, as the ventilator is giving a breath, okay, it's going to measure the peak inspiratory pressure. You'll see the little dial. Every time it gives a breath, you'll see the little dial. And if you hear that go off, meh, meh, the alarm, high pressure alarm, you need to get in there, take the person off the ventilator, and try bagging them. Because it's a high pressure, something's blocking the flow of oxygen down there. Could be a bronchospasm, they might need some albuterol. Could be a mucus plug, they might need to be hyperoxygenated and then suctioned, or my God, they could have dropped a lung. It might be a pneumothorax. But you better get in there and assess them right away. And that is the answer to any question relevant to a high pressure alarm. Take them off the vent and start hand bagging them with the Ambu bag. The other thing is as you're hand bagging them, you're feeling the compliance or lack thereof as you're giving them their ventilated breath, okay? A low pressure alarm means something in the circuit popped off. They might have coughed and popped off the end of their circuit, off their ET tube, or something down line could have happened. Make sure that you know the ventilatory bundle to prevent pneumonia, ventilatory associated pneumonia, okay? And that would be keeping that head of bed up at about 30 degrees, making sure that you suction everything you do with that patient. You better make sure that you are, I'm going to stop share here. Make sure that you are using sterile technique, you're washing your hands frequently. Make sure you're doing excellent oral care every shift, and that's with hydroxychloroquine. I do that every time, not hydroxychloroquine. Chlorhexidine. Hydroxychloroquine. No, chlorhexidine, and scrubbing their teeth and getting all that bacteria out of there, because that bacteria can transmigrate down into their airways and cause pneumonia. Did I leave anything off the bundle, Pam?
The delegation decisions, are they doing those kinds of questions?
Well, go ahead and review that. Just remember that you can't delegate anything you can't eat.
Real quick, before you guys start that, I do have some questions.
Okay, babe.
So one student had just mentioned that the chapter for ventilation is chapter 65, and the table is 65-10 for their addition.
Thank you.
And also, I had another student ask if you could go over the complications of PEEP one more time, and
Absolutely.
also what do they do for low pressure again?
Okay, perfect. By the way, thank you guys. Pop on anytime I can't find a page and help me out. I appreciate that. If you're looking at modes of ventilation, it's on page 1555, table 6512 in the newest book. And right above it, table 6511 talks about the different causes of the different alarms. So again, high pressure limit would be secretions, coughing, gagging, the patient's fighting the ventilator. So you need to sedate them if they're fighting the ventilator, reassure them. Sometimes it's just something like water, because remember, we humidify the oxygen, could be in the tube and you need to dump it. Which reminds me, make sure you dump the water out of the circuit before you ever turn your patient, or you can actually lavage them. Now, what could cause a low pressure limit is that the ET tube could be, there's probably a disconnect, okay? Somewhere there, something has disconnected from the ventilator to the patient's ET tube. So always go to the patient first and make sure the ET tube is still intact, right? Listen to lung sounds, make sure that everything from there to the ventilator is attached. If not, reattach it. That's what a low pressure ventilate alarm needs.
Hey, Di,
Yes.
real quick. The most important one, guys, assessment, low pressure, respiratory arrest.
Oh, there's a good one.
Yeah.
If they're not on a controlled mode and they're on like some assist controlled, or they might not even be giving them a rate, they might just have them on pressure support. They'll just put them on pressure support and let the person breathe on their own as we're trying to wean somebody off. So a low pressure alarm in that situation might be that the patient stop breathing. Okay, so that's a great thing. I'm looking for that bundle that I was telling them about. It's in here somewhere. Guys, don't forget that it's not just listening to lung sounds. You want to watch their thorax expand, right? You want to make sure that their respiratory effort is equal and symmetrical. If it's not, maybe they have a mucus plug down one side or what have you. Did I answer that question? Is there anything else somebody wants to know about?
The complications of PEEP, Di.
Oh yeah, I need to go over that again. Okay, so the increase in intrathoracic pressure can lead to decreased venous return to the heart, and therefore that would decrease preload, which would decrease stroke volume, which would decrease cardiac output, okay? It can also cause what we call barotrauma, actual trauma, pressure-related trauma to the lung itself. So it can blow up the alveoli. And if it blows up the alveoli, now you've got air where it shouldn't be, causing a pneumothorax, which could indeed lead to a tension pneumothorax. So those are the biggies. I'm trying to look and see if there's any other questions on ventilators or?
The other thing they mention in the book is ventilator-associated pneumonia with PEEP.
Yes, yes,
Okay.
because, yeah, that is true.
Electrolyte imbalances because of messing up the capillary alveolar exchange, the membrane permeability.
Okay.
That's going further down the line, I'm sorry.
Yeah, no, I don't think they're going to get that in depth. The big ones I think they're going to talk about are decrease in venous return and actual trauma to the lung itself. And that's when I'm looking at a pneumo or a tension pneumo.
And we had a student as well mention, sorry if I mispronounce this, volutrauma and barotrauma.
Volutrauma and barotrauma. Volume trauma and barotrauma. Barotrauma means any pressure-related atmospheric or pressure-related injury. And if it's due to the volume, usually too much volume, that's why when somebody has really stiff lungs, we decrease the volume and we increase the rate. And we usually set it at a pressure so that we know it's not going higher than that pressure so that we don't cause barotrauma. How are we doing, Eleni?
I don't see any more questions about that. While we have a minute, earlier when you were talking about ES3 and ES4, we had a student wondering if you could repeat those two.
Sure. ES3 we can wait and see. So that's probably somebody that, I'm looking for my little chart here again. That is probably somebody that just came in maybe with some cystitis or something. They're going to need some tests, but they can wait and see. ES4, they walked in the door. Okay, minor thing. Minor thing. ES4,
Strains.
yeah, exactly. Bruising, twisted ankle, that kind of. And ES5 is jive, meaning they should probably not even have came to the ER. Maybe it was a suture removal, or they got the sniffles or something like that. And there is a table in here, that's what I was reading from, and it's in your emergency nursing, just read through it. I'm just looking in here. You can read over the different phases and stuff of ARDS. Not that it's that important. Here for a second. Oh, risk factors for ventilatory associated pneumonia include impaired host defenses, invasive monitoring devices, which anybody in ICU on a vent is going to have, aspiration of GI contents. That's why we keep their head up, and you've got to monitor residuals if we're giving them enteral feedings. And we implement a bundle protocol, which says table 67-8 at the bottom of the page. Good hand washing before, during patient care, elevated head of 30 to 45 degrees, daily assessment of readiness for extubation. This is the one I had forgot before. Stress ulcer prophylaxis. So they're probably going to be on a PPI. In the new book, this is page 1600. VTE prophylaxis and daily oral care with chlorhexidine. And the VTE, venous thrombosis, that's what we're trying. So they're probably going to be on sequential compression devices, and they may be on some Lovenox. I'm going to look through here as we're talking about this. See if there's anything else that I need to tell you.
Really quick,
Oh.
Can you repeat what table you found the bundle?
Yes, table 67-8. In the new book, it's 1600.
Thank you.
You bet. Now, also, you guys, don't forget that evidence-based practice has shown that prone positioning and rotating your patient is very important, because in acute respiratory distress, yes, there are a lot of consolidated alveoli, but there's still, if you took your alveolar capillary membrane, you could spread it out, it would give you the surface area of a tennis court. So there's lots that's not being affected. So we want to prone position our patient, make sure we're rotating them so that we are incorporating, bringing into use those other alveoli.
Do the students need to know the indicators for weaning a patient from ventilators in depth?
I do not think so. Now remember, guys, I taught level 4 for years, but we don't see this test. We have no access to this test, and we leave it that way because I'm in a new role and I don't want to know what's on the test. I do not believe that is something that's going to be drilled down upon. But let's just think about this logically. We're not going to extubate somebody until they have a PaO2 that's normal, 80 to 100. We're not going to extubate somebody until their CO2 is within normal, 35 to 45, right? They're hemodynamically stable, and they're showing, and we're going to wean them. We're going to give them breaks off their sedation to see how well they're able to initiate their own breaths. They also can measure their negative inspiratory pressure, about how well they're able to inhale. I wouldn't go too much deeper than that. Pam, can you think of anything there?
No, I mean, that's, if they look at the table for indications of weaning, I think it'll make common sense to you guys. And just remember your criteria about oxygenation. If they're not showing signs and symptoms of tissue perfusion and oxygenation, then why would we wean them?
Right. Exactly.
So, I mean, like their hemoglobin and things. I mean, if they have a hemoglobin of 6, for heaven's sakes, they don't have the screen. Yeah.
Can you
Hemoglobin.
guys, oops, sorry.
No, go. Go,
Can
Lainey.
you guys go over VQ mismatch?
Sure.
Good one.
All that means, I'm going to share my screen again here. I wouldn't get to, they're not going to, trust me, they're not going to drill down on this. This is really a very clear all drawings. Okay. Okay, so Again, for every 1 unit of ventilation, that is an alveoli, not a nose, by the way. For every unit of ventilation, there should be an equal unit of Q, perfusion. I don't know why it's not a P, but it's a Q. So it's called a VQ. Now you have a VQ mismatch when one of those has an issue. So let's think about this. We can have ventilatory issues. We can have fluid, like we just talked about in ARDS, or an atelectic alveoli, and now we have shunted blood. It's called wasted blood flow. That blood is flowing by an alveoli that cannot participate in gas exchange, okay? That, and then you can have it on the other side. You could have a wide open alveoli, and you could, like Pam was just saying, have maybe just 6 cars on your hemoglobin train, and or you could have a big old fat pulmonary embolism and blood's not getting here. Now we have wasted ventilation. That's what a VQ mismatch is. Okay, what do? I correct the problem. So I'm going to be looking at my ABGs and then going from there.
I had a student who wasn't present for the first part of the meeting, is wondering if this is on the NIP review packet.
The NIP review packet, the NIP handouts, there is a ventilation thing that's in there, yes. There's a whole thing on PEEP, there's a whole thing on ARDS, and I went through it in great detail on the almost 3-hour workshop I did. That's also in the NIP Commons.
Thank you.
You bet. Okay, what next, guys? Did we cover that in great enough adequacy for you? I'm just looking here.
And Di, everybody, I don't know, I'm just butting in, but FiO2, fraction of inspired oxygen.
That's
Right?
what that means, yes.
Okay.
Yes, good.
And room air is 21%, correct?
0.21, mm-hmm.
Okay.
Yes.
We have a student who's wondering if you guys can go over partial compensation and full compensation for ABGS.
Yes,
Oh,
I can.
good.
Here we go.
Awesome.
All right. So remember, in order, and mainly what you're going to be seeing is, okay, stop already. I want to draw myself. All right. So if we have, let's say we have, remember, you got 735 to 745. You guys better write down your normals, and don't forget that the absolute perfect number is 7.40, okay? And that is really going to come into play when we talk about compensation. So the first thing we always do is we look at our pH. Then number 2, we look at our PaCO2. I'm writing with my finger, that's why it looks like a chicken. And we make sure you put 35 to 45, right? Remember, if you don't change those, you're going to be screwed. And 3 is our bicarb. And that's, I think it's 22 to 28 now in your book, okay? The old book was 26. Go by what your instructors told you to go by, okay? I'm going to put 28 there because that's what's in the new book. All right, so let's say our first patient is 7.36, okay? 50 and 27. All right, so I tell you guys, what is the 736? Make sure you come up here and then look, that would be way over to the left, and you write acid to the left. So this person is in acidosis. And then you look.
Hey, Di, I'm sorry, 7.36? That's within norm.
I'm sorry. Thank you, Pam.
No problem.
7 point. Let me just change this for a minute. Let me change it to. I want to do one without compensation. I got ahead of myself. Let me just go 733. Okay, 733. 733 would be acidosis. Thank you, Pam. And a CO2 of 50 would be acidosis. So I write it to the left because that's where acidosis lives. And a bicarb of 27 is normal. Go back to your blood state. What are you in? I'm still in acidosis. Which one of these? Remember, these two things, your CO2 and bicarb, drive your pH. Your pH won't move unless one of those moves. So which one says the exact same thing? My CO2, which is my respiratory component, so I'm in respiratory acidosis. Now remember, when we talk about compensation, the only time compensation can be occurring, the only time, is when the CO2 and the bicarb are both out of range opposite. One says acid, one says alkalosis. Listen, if they both say acid, that's a combination respiratory and metabolic acidosis. There's no the compensation has failed and they're dying. So this same person, this person who's respiratory acidosis, who could very well be a patient in ARDS, okay? What's gonna happen is their kidneys are gonna start holding on to bicarb and excreting hydrogen. Now that might take hours to days. Whereas when your chemoreceptors sense excessive acids like hydrogen, CO2, if they start sensing high hydrogen ions, they'll start blowing off the other acid, CO2, and that can happen within seconds to minutes. But it takes the kidneys a little bit of time. So let's say hours from here, like 12 hours later, we come in and we see 7.3, that's not good, 34, and 50, and 30. Okay, so we're like 734, that's still acid, okay? And 50 is still acid, but look what happened. Now I have a bicarb that says alkalosis. So I go back here and I say, okay, I'm still in acidosis. What matches it? My CO2, so it's still a respiratory acidosis. However, I've got to function in my bicarb that's going the other way. Anytime your CO2 and your bicarb are out of range opposite, you have some form of compensation.
Okay.
There's only two forms. Either it compensated so well your pH is back to normal, which here it's almost, but it's not quite. So this is just a partial. All right, stay with me. This same patient, I got to do a little erasing here. Hold on a minute. Eraser.
So to clarify while you're doing that, for compensation to occur, both the CO2 and the bicarb are abnormal, but they are in opposite directions.
Thank you, Pamela, for that, because you better remember that, you guys. Now, this same patient later might look like this. 7.3. Oh my gosh, that's a 3, I promise. 6. And what did I say? 50 and 30. Okay, so you come in here and you go, oh, 736, that's right here. That's normal. And then I say CO2, that still says acid. And the bicarb of 30 still says alkalosis. Now I go, this was something that compensated. And since my pH is back to normal, I have full compensation. This is, I don't know where that came from, but anyway, this is where you have to bring down the 740. And you write it 740. Okay, that's your number there. Is 736 to the left acid side of perfect? Or is it to the right alkaline side? Well, obviously 736 would be to the left. So this was an acid. This is so messy, sorry you guys. And what matches it is still your CO2. So in this case, I have respiratory acidosis that fully compensated. Eleni, did that help that student? They can click, guys, if you just click your space bar, I can hear you. So whoever asked that, if this does not make sense, please speak up.
So what makes something fully or partially compensated is whether or not the pH is within normal range. So if the pH is within normal range, but it's to the left of perfect, then it's, no, I'm sorry. If it's within range, it's fully compensated. If it's out of range, either way, it's partial compensation based on what we already learned in ABGs in third semester.
Brilliant, Victoria, brilliant. Now, let me ask you this, Victoria.
I don't know the answer.
What, baby? No.
I don't know the answer.
Yes, you do. Come on.
Just
try it.
remember that's exact. You said it brilliantly, but just remember that the only time a compensation is occurring is when both the CO2 and bicarb are out of range opposite. One is saying acidosis and one is saying alkalosis. Let me do another one, okay? All right, guys, let me write my normal here again.
And,
They
and
might just put a totally normal blood gas on there.
Yeah, don't flip out about that.
And Di, when you're done with this, the only other question that I saw in the chat is if you could go over continuous bubbling with the chest tubes versus constant.
Oh, sure. Yep, I will. In fact, I'll go get my chest tube and show it to you.
Thank you.
All right. So we have pH, we have CO2, and we have bicarb. Okay, remember that, guys. All right, here, let's say this person was in profound shock for a long period of time, and here's what they look like. 7.32 30 and 35 and 12. Okay, always go 1, 2, 3. So the first thing, 730, that would be over here. So I'm going to write acid to the left. Everybody sees that, right? Then I look at my CO2. My CO2 is 35. That is still normal, okay? And then I look at my bicarb, which is 12, which would be way over here. So that is also acid. So I know I'm in an acidotic state. And what matches with it is my bicarb. So I have a metabolic acidosis. Now I look at this and I say, am I compensating? No. How do I know that? Because I don't have both my CO2 and bicarb out of range, okay? But a little bit later, let's say it looks like this, 7.39 and 30 and 12. Well, when I look at 739, that would be right here, would it not? Okay, that's normal. And a CO2 of 30 would be over here, so that's alkalosis. And a bicarb of 12 would be over here, so that's acidosis. Now, this is where I have to look at it and say, okay, my CO2 and bicarb are out of range. I have some form of compensation. And because it is within normal range, I have full compensation, okay? Now I have to go back and figure out what was the cause. And the way I figure that out is I put my number of perfection, 740, right above my pH. Even though my pH is normal, is it to the left side of perfect or is it to the right side of perfect? Well, you know, 739 would be sitting right here towards the acid side of perfect. So this was an acid. Well, what also says acid? My bicarb. So what this was a metabolic acidosis that fully compensated. Okay? Does that make sense? I want you guys to understand ABGs because they're just like math. There's no questions. It is black and white.
I have a question from a student. Oh, I have several about this before you get to the
Yes, go.
test tubes. She was asking, in partial compensation, will it always be respiratory?
No. Partial just means the CO2 and bicarb are out of range. Well, I just showed you a example of metabolic acidosis that was partially compensated and then became, well, this was a full compensation. Compensation is always when the CO2 and bicarb are out of range, okay? And when they are, if the pH is perfect, then that's full compensation. If it's not yet back, that's only partial. Okay, but it can be partially compensated respiratory acidosis, partially compensated metabolic acidosis, partially compensated metabolic alkalosis, partially compensated respiratory alkalosis. Okay, it's like a teeter-totter. Think about that person in DKA, diabetic ketoacidosis. They're holding on to hydrogen ions. They're in metabolic acidosis. So what's going to happen? They're going to try to blow off CO2 with Kussmaul's respirations, okay? So no matter what abnormal gas state the patient goes into, their body's going to try to take them to the absolute opposite in order to get back in balance. I hope that makes sense.
And the other question regarding this is if pH 7.4, PCO2 50, HCO3 30, what is this? Is it fully?
Okay, let me clear this off. Okay, give me the numbers again, Eleni.
Okay, pH 7.4,
Okay.
PCO2.
They're not going to do this to you, but go ahead.
PCO2 50,
Uh-huh.
HCO3 30.
Uh-huh.
The student's wondering, is this fully compensated respiratory acidosis or fully compensated metabolic alkalosis?
Okay, let's go through this. Let's go through this. They're not going to give that to you. You would have to look at your patient. They're not going to give that to you. I'm telling you that. You will never, your body's never going to fully compensate like this, okay? So probably it would, and I would look at the patient and I would say, were they having trouble breathing? Then I would go with respiratory acidosis.
Or do they have
It
diarrhea?
wouldn't have been a metabolic alkalosis unless they took a whole bottle of Tums or we gave them IV bicarb, okay? You're not going to have that question. Just going to tell you straight up, okay? Most likely that would have been a respiratory acidosis and we intervened and gave some IV bicarb. Okay, I hope that answers that.
And the only other question I just wanted to revisit it is the one about constant bubbling and continuous bubbling with chest tube.
All right, give me 30 seconds, Pam. You can talk about whatever. I'm going to go get my chest tube.
Well, I'm
I love that she has props.
always Miss B does. Your chest tube should be in your chapter called lower respiratory problems. I'm sorry, I don't have the latest version of the book yet. I'm still in the old version. And the things that you want to think about, because they're going to try to tie in trauma, think about your signs and symptoms. The tension pneumothorax. So what would give you an indication that it's a tension pneumothorax? Asymmetrical chest movements. What's the number one? Tracheal deviation, right? The trachea will alter as far as not midline. The definition of a flailing chest, that would be multiple rib fractures, and the chest movement would be opposite of what you would anticipate. When you inspire, your chest wall does what?
Comes out,
It,
expands.
yes, and when you exhale, your chest movement will decrease.
Coil.
So I was just saying, think about the traumatic chest injuries, tension pneumothorax, tracheal deviation, flailing chest, multiple rib fractures, and those signs and symptoms.
Brilliant.
A sucking chest wound.
Like from a gunshot or a
Stabbing.
knife, whatever.
Yeah.
Remember, we don't fully occlude it. We do a gauze pad taped 3 sides so that when the person inhales, it keeps them from inhaling more air, but when they exhale, that bottom flap that's open will allow air to escape, because if not, we're going to build up more air in that pleural space and cause our pneumo to become a tension pneumo.
Okay.
Okay, here's the chest tube. All right, this is a watered one. It doesn't matter if it's water or it's a dry system, but this side here is where you fill the water to the desired sonometer of suction, and then you hook it up to suction. You want to see continuous bubbling in the suction chamber, okay? In the suction chamber. That's the only place we want to see continuous bubbling. This little one down here, the air leak indicator, all right? You may see a little bubbling down there when we first put the chest tube in until we get a negative suction on it. Then we should not see continuous bubbling in the air leak indicator. If we do, we have a leak. So then we have to take down the dressing and look at where it is into the thoracic cage and reapply some like Vaseline gauze and an occlusive dressing and make sure that all of our connections throughout that tubing to the chest tube are secure because we have an air leak, okay? What you may see down here in this air leak indicator is as the person inspires, it rises, and as they expire, it falls. That's called tidling. It's just that water moving. And the reason we have water down there, it's just like, if the chest tube ever came undone, God forbid, let's picture a chest tube hanging out of my side, I'm gonna be sucking air. So what I would do is take that chest tube and put it in a bottle of water or any kind of fluid so that I can't suck air back in. That is the whole purpose of this air leak indicator. Down here is it's to prevent air to go back from going back into the thoracic cavity. So if you see tidling, that is normal. When you see tidling stop, you may go check the patient because they probably re-expanded their lung. These three are your collection chambers, and every shift you're going to make a mark of what time it was and date so that you can determine how much like serous or serosanguinous drainage that you have. Did that answer the question about the chest tube? So two things, if the chest tube rips out of the whole chest, you put a gauze pad and you tape it on 3 sides so that when they inhale, they won't get any more air in, but when they exhale, that air can escape. If the chest tube is still intact, coming out of their thoracic cavity, but it disconnects from the tubing, get it into some sterile water. That will be an air leak. That will be an air, what am I trying to say, Pam? That will prevent air from going back up into the thoracic cavity.
So
All
it
right?
has to be sterile water, correct?
Yes.
It should be sterile water. Let me just tell you this. If that happened to me in one of my ICU patients and I had a bottle of urine sitting there and I didn't have sterile water, I'd stick the chest tube in the urine. Liquid to prevent them from getting a pneumo. But yes, on the test, you need to have sterile water there. Do we ever clamp chest tubes? No, we do not. There's a very rare occasion, okay? If we have to change out systems, and evidence-based practice shows that we need to try to avoid that at all costs because we can actually indeed cause a tension pneumothorax. Don't forget about trauma in the fact that your signs, okay? Remember, you've got a lot of solid organs in your abdomen that are very vascular. So think about Cullen's sign, where you see bruising around the umbilicus, and Gray Turner's is when you turn them and you see bruising in the flank.
A student
Okay.
is wondering if if it disconnects from the reservoir.
If it disconnects from the reservoir.
She's trying to confirm if what you were just discussing.
Yeah, if let's say this
Anywhere in
came
the
off,
system.
as long as the chest tube is still in the body, put the end of and it gets disconnected from the reservoir, put the tube underwater. If the whole chest tube comes out, that's when we put the 3-sided gauze.
And if anyone's wondering, we had a student inform us that chest trauma and chest tubes for the 10th edition starts on page 519.
Thank you.
Mm-hmm.
Any other questions related to that?
I'm not seeing any.
Okay. Any other questions?
Oh, you were starting to explain Gray Turner's sign, Di.
Oh, thank you.
Yeah.
With trauma, the other thing you got to worry about is turning that patient and looking for bruising back in the flank because maybe you've got kidney damage. Okay, so those are all things. Rhabdomyolysis. I had that after my plane crash. If there's a lot of crush trauma, the myoglobin, those big proteins from the muscles, will leak out into the pipes and flow downstream and get stuck in the millions and millions of nephrons and cause acute renal failure. So you want to look for myoglobinuria. That is a dark brown urine. Remember, guys, your kidneys are the eyes into the soul of the cardiovascular system. You've got to be seeing 30 mils an hour, or 0.5 mils per kilogram. Make sure when you're looking at your shock states, and of course now I've lost that page, where, I'll find it again, where you
Compensatory.
know the difference. Somebody's unmuted. Oh, here it is. It is for in this book, somebody can shout it out in the old book. I have table 66.3, clinical presentation of the types of shock. You need to know the different types of shock, what is unique to each one, because that is what you're going to focus on. Okay, remember, I talk about perfusion being the pump, which is the heart, pushing the precious prime. So if the pump has shock, that's cardiogenic shock, right? And what's unique to cardiogenic shock? Let's just start there. Cardiogenic shock is can be due to having an MI, could be from cardiomyopathy, it could be from blunt trauma to the heart, it could be any of those things. And what are we going to see? Now, normally when we're in shock, if we lose volume, right, we're going to have our blood pressure go down, we're going to have our heart rate go up. Okay, that's going to happen also. We're going to have our blood pressure go down and our heart rate go up. But what's different in this kind of shock, let me just blah, 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 let me draw again here if I may, you know I have to draw, is that in this shock, okay, the preload, the pressure in the right side of the heart, I'll go away, my internet connection is unstable, and the preload in the left side are going to be elevated. How do I measure my preload in the right side of my heart? My CVP. So this is the only shock where the CVP is going to be up. And to measure the preload in my left ventricle, it's the pulmonary artery wedge pressure or pulmonary artery diastolic pressure. All right. So that should be less than 12, and this should be less than 8 millimeters of mercury. If those are elevated, that is cardiogenic shock. The only other thing that is specific to this is the systemic vascular resistance. That means how much resistance is there in the pipes leaving the heart. And this is very synonymous with my afterload, okay? So that is what is specific to cardiogenic shock. We have decreased cardiac output, we have decreased, we have increased SVR, and where is it? Cardiogenic shock. Decreased stroke volume, decreased cardiac output, increased systemic vascular resistance, increased pulmonary pressure, increased CVP, decreased capillary refill. What are we going to see? Well, remember, everything's going to back up. So what comes up back from the left is going into lungs, crackles, shortness of breath, tachypnea. Cyanosis, guys, that's a late sign. That's a PaO2 of about 60. Skin's going to be cold and clammy. Now remember, my razzmatazz is going to kick in, so I'm going to see, because of the decreased cardiac output, I'll have decreased renal perfusion, so decreased urine output. I'll be holding, razzmatazz is going to kick in, so aldosterone is going to be secreted. I'm going to be holding on to sodium, trying to pull water back. This is making it worse. Your body doesn't know why it's not perfusing the kidneys, it's just not. So that's why we give medications to block RAS. We want to unload this patient. We're going to give diuretics, right? We're going to give positive inotropics, things to increase the force of contraction. We're going to unload the heart by giving vasodilators, okay? And this person might need to get put on an intra-aortic balloon pump and or an LVAD. And think about what kind of diagnostic markers might you see? Well, if they had an MI, troponins are going to be up. My BNP is probably going to be up because I'm in failure. Blood glucose, that's up a lot because of stress, because of cortisol. My creatinine, BUN, might be up because I got poor kidney function. And my echocardiogram, which tells me
Ejection fraction.
ejection fraction, and that means how well is my contractile force of my heart. Anything less than 50 is cardiogenic shock. And more specifically, remember this, a cardiac output It should be 4 to 8 liters. A cardiac index is when you take the cardiac output and divide it by the person's body surface area. Anything less than 2.5 liters a minute is cardiogenic shock. So read your scenario clearly. It's going to be a puzzle, and you're going to go, even before you look at any of the distractors, you're going to go, this patient's obviously in cardiogenic shock. I need to unload them. I need to promote cardiac function. I've got to watch for dysrhythmias. Say the picture in your head and then look for the answer.
And
Guys,
if
we
it's,
have, oh, I'm sorry, Pam.
no, it's okay.
We have a student wondering why you give IABP when a person's in cardiogenic shock.
Okay, so here, if somebody's in cardiogenic shock, they have decreased cardiac output and they have increased systemic vascular resistance, increased afterload. So if I float the intra-aortic balloon pump here, now remember, it inflates and deflates in timing with the heart. So this is ventricular systole, the rest is diastole. During diastole, guys, that balloon is going to inflate and it's going to push blood back into the coronary arteries so I can feed the heart. And it's also going to increase cerebral blood flow. It's going to help the pump. Then the other thing is right with the R wave. Let me see if I can. Okay, I don't want to stop share. Go away. I need my eraser. Here we go. Right when it happens in diastole, that balloon deflates, okay? And what does that do? That allows, oh my God, that allows the heart to eject more easily. That decreases that systemic vascular resistance. It decreases the afterload. So that's how the intra-aortic balloon pump works. They also have a new thing called the Impella, which actually sits down in the left ventricle and spins and helps unload the heart that way. Kind of works like the LVAD, where they take the blood right out of the left ventricle and use a centrifuge kind of pump and then pump it back right into the aorta. But you can imagine all the complications of that. And the bottom line is we got to fix the problem. So if it's coronary artery disease, they need to go have a CABG or PTCI or what have you. Or God forbid, if it's really damaged the whole heart, because 80% mortality with cardiogenic shock, they may be on a transplant list to get a new heart. I hope that helped. Okay, Eleni, any other questions?
I don't see any at the moment.
Oh, all right, well, let's just keep going here. We talked about the pump shock, okay, so that's cardiogenic. Now let's talk about the prime shock, which is hypovolemic and hemorrhagic, okay? All right, now remember, in hypovolemic, it's absolute or relative. All that means is I don't have enough fluid, plasma, water in my river, okay? Absolute means I've absolutely lost it out of my body, either through urination, either through vomiting.
Diabetes insipidus.
Yeah, exactly. Relative means I have lost fluid out of the river, but it's not totally out of my body. I've third spaced it. So this might be somebody who has ascites. This might be a burn patient where they're third spaced and they have anasarca. That fluid is no use to them. We got to get it back into the pipes. So in hypovolemia, think about it. I'm going to have, my heart rate's going to be up, right? My blood pressure is going to be down. And obviously my wedge is down, my CVP is down, everything's down. And what's going to be high is my sodium will be up because I'm high and dry, and my H and H will be up because I had this hemoglobin train running through a dried up river, okay? So hypovolemic, so what do you see? You see that person who has dry mucous membranes. They are pale, they're weak thready pulses, they've got a poor urine output, it looks like crude oil. What do we need to do? We need to hit them with some, like probably 2 big IVs and get isotonic saline into them, all right? They need to have fluid replacement. And after we replace so much fluid, then we have to start thinking about replacing blood components. If the person has hemorrhagic, It's the same thing. Heart rate up, blood pressure down, but their H and H will be down because they've lost red blood cells. Okay, so what do I need to do? Give them red blood cells. We remembered that we never give anybody something they don't have, so we can give the universal donor before we type and cross match. We can always give O negative. Okay, but remember, when you're giving red blood cells or packed red blood cells, there's no clotting factors in there. All of our clotting factors are in our plasma. So after so many units, like 2 units of packed red blood cell, you have to give a unit of FFP, fresh frozen plasma. And you may have to give cryoprecipitate, which has factor 8 and von Willingham's. Okay, and you have to watch those thrombocytes. They need to be higher than 150,000. Otherwise, you're going to be given some platelets. All right, and how do? You got to figure out what's bleeding and stop the bleeding. Okay, those are the big things with hypovolemic shock. Remember, anytime somebody's in a what I call piss poor perfusion state, when they don't have enough perfusion to make urine, they're going to have a change in level of consciousness. That is across the board with all shocks.
And the IV of choice for fluid volume replacement?
Always normal saline. Pam, I'm glad you brought that up.
Not
Well, you say, Miss B, lactated ringers is also an isotonic. Yes, it is, but here's the deal. When you're in a poor perfusion state, you're risking going into MODS, right? And all of your organs are not functioning well. One of the purposes of your liver is not only to make clotting factors, it's also to take lactate, right? And make it into bicarb. It can't do that if there's poor perfusion. So we're not going to give them more lactate, like lactated ringers. We give them normal saline.
We have a student confirming H&H is down in hypovolemic shock, but up in hemorrhagic shock.
Just the opposite. Just the opposite. Think about this. If I'm losing volume, I'm dry. My riverbed is dry. So think about it. If a river is flowing, you can't see all the rocks down there. But if I'm hypovolemic and I've taken half that water out of the river, I can now see those solid particles being red blood cells. So if my H&H is high, I'm intravascularly dry. Hypovolemic shock, your H&H will be up. If you're losing blood, it goes to reason, then your H&H would be low. I hope that cleared it up.
The reason why they're asking it, it was presented that way under clinical manifestations in one of the tables. I just saw
That the H&H,
yeah, hang on. If you look at manifestations,
clinical presentation of types of shock.
I just had it. I'm sorry. Give me a second.
Right here it says hypovolemic shock. It does say down there that the H&H will be low.
Yes.
They would have to be losing blood as well. Okay. If they're losing blood, then it would be. If they're not losing blood, it won't be.
Right. If they're losing whole blood, correct?
Because guys, realize that hemorrhagic is a form of hypovolemic shock. Okay.
Absolutely.
So let's look at it that way. Okay, what else? Remember, now you think about your pipe shocks. And your pipe shocks, meaning your arteries, your arterioles, your capillaries. You have anaphylactic, and obviously with anaphylactic, there's going to be an antigen that causes you to have a massive release of histamine. You're going to have stridor, bronchoconstriction. You're going to have hives. They're going to have feeling of impending doom, and their cardiac output's going to go up. It's a very hyperdynamic state. Everything else is going down. They're going to have shortness of breath. They may have incontinence, flushing, pruritus. They're going to feel very, very anxious. And they're going to have abdominal cramping, the whole 9 yards. What do you need to do? Stop the inflammation. So we give them epinephrine, which is a sympathomimetic that will bronchodilate, right? And it'll help vasoconstrict these vasodilated arteries that are leaking, vessels that are leaking. And we also give Benadryl to stop the histamine. We're giving the antihistamine. And then get whatever the causative agent is away. And then that person's going to probably have to carry an EpiPen the rest of their life. The other one is, so that was anaphylactic. Okay. Then we have neurogenic, which we went over when we did our first test review. Neurogenic is usually due to a spinal cord injury above T5, and you better know what's specific to that. You're going to see bradycardia, because it's just like taking an electrical cord and breaking it. There's no more sympathetic stimulation. It's all stopped. So the only thing that is working is the parasympathetic, which is my feed or breathe. So it's going to go, okay, let's just hang on with bradycardia. Treat the bradycardia, give atropine. They may need a pacemaker. We have to remember, this is pipe shock. My pipes are vasodilating, so I need to give potent vasoconstrictors. So here's when I'm going to be giving epi and possibly norepi, ephedrine, norepi, really potent vasoconstrictors, and then treat the cause. Okay, and this person's going to probably have flaccid paralysis below the level of the injury, loss of normal reflex. It can also be due to, though, anesthesias. So it could be that somebody had a spinal anesthesia. Go ahead, Pam.
Pain.
Pain. Yes, if you had, in what way, Pam? Explain that. Pain can cause neurogenic shock?
That was one of the,
Okay. That'd have to be some severe pain, I'll tell you.
well,
I got you. I'm thinking that it's got to be because pain.
well, you're going to peripherally shut down. You're going to be in that fight or flight mode, correct?
But that's sympathetic, and neurogenic is loss of sympathetic.
Yeah.
So
But-
pain doesn't make sense to me. Let's not talk about pain, unless you can figure out where it says that, because that doesn't make a whole lot of sense to me. The other thing about neurogenic shock you may see is poikiliothermia, where they lose the ability to vasoconstrict in their lower extremities when it's cold and vasodilate when it's hot. Okay. The last of the pipe shocks that is really bad is septic. Don't forget about this one. Remember, sepsis is
Professor Burgess, before you
yes,
move
Victoria.
on to septic, when you said vasoconstrictors about norepi and epinephrine,
yes, ma'am.
Could dopamine is included in that?
Dopamine is a vasoconstrictor. Yes, it is not as potent as epi or norepi, but it is. Yes, love. And dobutamine. By the way, you brought up a good point, Victoria. When you're in pump shock, we want to increase inotropic force. Dobutrex is fabulous for that. And Dobutrex also causes a little dilation to the renal arteries. So Dobutrex is a great drug for cardiogenic shock, as well as Inocor. Inocor. Thank you. Okay, remember, septic shock, guys, is the Mac Daddy of all shocks. It has a really high death rate, and it's a life-threatening syndrome. A lot of times, up to 30% of the time, we don't even know what microorganism is. So sepsis is either a documented or suspected infection. There's some kind of microorganism in the patient, and it's causing hypotension. So what happens is this microorganism gets into the body, and it has a release of endotoxins. Those are toxic substances that destroy the endothelium, meaning the inner layers of your artery and your capillaries. And so then what it does is it lets your capillaries start leaking, and fluid starts leaking out of your capillaries, which is never, never, never good. Okay? So septic shock is we have that suspected and or documented microorganism, and we can't get our blood pressure above 90. And then severe sepsis is when we start seeing this on top of the fact that we have end perfusion, end organ bad perfusion. We're not putting out urine anymore. We've got problems with our respiratory situation, what have you. So the big things with septic is that there is some kind of a causative organism, and we call this warm shock, pink shock, because they are going to be flushed and they're going to have a fever, so they're not going to look that pale, shocky look. They're not going to be clammy and cool. They might be warm to touch in special areas and have, pink flushed face. And that might fool you, okay? They are probably going to have a temperature. Now, If you have sepsis, you have SIRS. But SIRS can be caused by other things. So SIRS is a systemic inflammatory response syndrome. And some of the identifying markers of somebody who has SIRS, and remember, if they have sepsis, they have SIRS, is the fact that they're going to have a temperature that's elevated or it's going to be below normal. And I'm just trying to find my little thing here.
The book says a temperature greater than 100.9 or a temperature less than 97 Fahrenheit.
Perfect. I'm going to stop share this for a second, and I'm going to go pull up my thing.
Would
Go
be
ahead.
for leukocytosis or leukopenia.
Right.
Okay. You talked about the blood pressure being the systolic blood pressure less than 90.
Right.
They could have things like hyperlactemia.
I have a
Yeah, their
quick question.
lactate level goes up. Go ahead, Elaine.
No, this is Jewel. Do we have access to that packet?
Yes, absolutely. This is what I
Okay.
use to teach the
Because I didn't see
workshop.
anything in the NIPS, like for test 3, there's no folder for test 3. Maybe that's just me.
It's level 4. I don't know how Megan set it up. I know I saw them in there. They're the handouts.
Yeah, because it has each level, and then it goes into each test, and it says test 1, test 2, and then test 4. But I'm not
Yeah,
seeing.
it skips test 3 for some reason. I don't know.
Yeah,
gotta
it
be
skips
kidding.
test 3.
This stuff isn't in test 3. Okay, I tell you
There's
where
no
you.
folder for it, but I think if you go into, there's another folder down there that says resources. There may be, I think that's where I
I
got
looked
mine
under
from.
supplemental materials,
Yeah.
not under there either.
All right.
I found it. I found it under, there's a folder for test 3. That's where I got mine.
Yeah, for some reason I don't have it. It's strange.
I didn't either.
You have to
That's
click.
weird. When did you girls look that couldn't find it? When did you look?
I'm looking right now.
You have to go under, it's like under test 1, and then there's a folder that says test 3.
Oh,
Under
I see
test
it.
1?
Another student has suggested that you click on the theory tab to see it.
Yeah, you have to go to theory, and then you go to test 1.
Yeah, it's under test 1. If you hit the theory tab, you won't just see it. You have to hit test 1 first, and then it
Yeah.
has
Okay,
like a
so I'll
subject.
ask Lisa Di.
Yeah. Okay, perfect. Oh, thanks. Sorry, guys. Sorry about that.
No, it's okay. Thank you.
So here's the sepsis, the systemic response to suspect or documented infection. The severe sepsis is complicated by organ dysfunction, septic shock, sepsis with hypotension, regardless that we've already, despite that we've given them adequate fluid. How do I know if I've given them adequate fluid? Their CVP has to be 8, okay? Here's what Pam was talking about. We're gonna have increased temperature or it's gonna be down. We're gonna have an increased metabolic rate. These people have a bounding pulse. That's the only shock, that you're gonna find a bounding pulse. And a lot of because of that endotoxin causing the capillaries to leak, we're gonna have respiratory failure in about 85% of these people. They go right from SIRS, sepsis into ARDS, and then on into MODS. Decreased urine output, they're gonna have metabolic acidosis because they've gone from aerobic metabolism into anaerobic metabolism, okay? So temp less than 100.9, I'm sorry, greater than 100.9 or less than 97, heart rate greater than 90, tachypnea, so a respiratory rate greater than 30, or they're blowing off CO2, so a CO2 less than 35. Leukocytosis, WC greater than 12,000 or less than 4,000. Arterial hypotension, where your systolic blood pressure is less than 90, a mean arterial pressure less than 70, or a drop in systemic blood pressure of greater than 40. Paralytic illness is always an issue, and obviously oliguria. What do? We treat them with crystalloids. Got to get that CVP up between 8 and 12. We're going to give them, we're going to culture them, pan culture them, everything, urine, sputum, blood, and we are going to give broad spectrum antibiotics, okay? And don't let this interfere with waiting for the culture and sensitivity. But remember, broad spectrum antibiotics are very harsh on the kidneys. And then the supportive measures to maintain hemodynamic stability, and the big bad vasopressor is norepinephrine or Levophed. Intravenous hydrocortisone, that is kind of controversial. I want to go into SIRS. Where's our SIRS? Yada, 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 yada. Obstructive shock, guys, you know, you have to get rid of the obstruction, whether it's a pneumothorax or cardiac tamponade. Eleni, can you still hear me?
Yes, I can.
Okay, I just lost Pam and I didn't know where she went, so I just want to make sure I hadn't lost you
Oh,
guys.
okay.
You lost me? No.
You're here, Pammy? I just couldn't see you, baby. Okay, there you are. Okay, so remember, a pulmonary emboli, tension, pneumo, cardiac tamponade. Superior vena cava syndrome is when there's like cancer or something pressing against that vena cava. Abdominal compartment syndrome from trauma or what have you. And the bottom line with obstructive shock is that the cardiac output is decreased because of increased afterload. Those are the people you're going to see JVD, possibly pulsus paradoxus, where the systolic blood pressure drops when they inspire. Always airway, 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 breathing, circulation, fluid resuscitate them. And then that's usually when we have to go in and either do a pericardiocentesis or insert a chest tube or do a removal of fluid from the abdomen, a paracentesis, what have you. All right, let me stop that share and let's go to, any other questions, Eleni?
I have not gotten any more about that.
Okay, I thought I had my, I thought I brought up the DIC. I thought about going into SIRS, ARDS, MODS. I kind of talked about ARDS already.
There's a table of manifestations in their book labeled SIRS and MODS towards the end of their critical care chapter, Di.
Okay. Okay, perfect. I don't think I'm sharing this with you guys yet. Get you back up, y'all. And
I do have a student asking if you guys can go over ARDS/SIRS, SIRS, or possibly DIC.
yep, I was just getting ready to go into DIC here, but do you see that up on your screen yet, DIC? Probably not.
I don't see anything.
All right, hold on a second. I got to get back here. All right. Okay, now I got to hit share screen. And where's my DIC? There it is. All right. So just remember, we're going to go back to SIRS, but SIRS is systemic inflammatory response. Okay. So you have a little bit of localized inflammation is good, but when it's all over the body, it's horrible. It's secreting all those cytokines, histamine, prostaglandins, tumor factor, all those cardiac suppressant factor that are going to make the body die. Now, when you have pro-inflammation, you have pro-coagulation. They go hand in hand. So DIC is also called disseminated intravascular coagulation or coagulation consumption coagulopathy. SIRS starts it. Not only are you leaking your pipes from inflammation, now you're also promoting clotting, because whenever you have an injury, you're going to try to clot, okay? So what's happening, this is not a disease, it's a complication resulting from a disease or a disease process. From what we're talking about, it's from prolonged shock, or it could be from trauma. I went into DIC after my plane crash because I lost so much blood. I was in hypovolemic hemorrhagic shock. So a lot of times it's due to sepsis infection, especially gram-negative, bacterial, but it doesn't have to be an infection. It could be an obstetrical complication. You guys learned about this when we talked about placenta abruptia. It could be heat stroke, any kind of shock, but specifically septic, cardiac arrest, giving incompatible blood transfusions, transplant rejections, a poisonous snake bite, crush trauma. Regardless of the cause, DIC is a serious bleeding order because they use up all their clotting factors. So go with me. So there's an accelerated clotting process. You're not going to have to know this detail, but I want you to see it. Prothrombin, okay, becomes thrombin, and thrombin is the most potent coagulant catalyzer. Remember, everything in the clotting factor, one thing, it's like dominoes. This one hits this one, and this one hits one. There's always got to be one thing going into the next. So once we form thrombin, prothrombin becomes thrombin, then fibrinogen, it's like putting fiber in a gin, like a cotton gin. And what happens is we make a spider web. Okay, so fibrin is a sticky matrix that lays down in your pipes so that as the red blood or the platelets get through there, they stick into that fibrin and they make a thrombus. The excess thrombin converts fibrinogen, a sticky protein, to fibrin, a matrix material resembling a spider web, producing fibrin clots in the microcirculation. So all your smallest vessels are going to be the first ones to clot. Your kidneys, your fingers, your toes. All right, that sticky fibrin matrix promotes platelet disposition in capillaries and arterioles, leading to thrombosis and ultimately small vessel occlusion. Clots or thromboses within the blood vessel lead to decreased perfusion. Obviously, if I've got a big clot in that pipe, I can't get perfusion past it. The decreased perfusion leads to ischemia, injury, infarct. You know the drill, and without treatment, loss of cell function. The ischemic cells are going to go from aerobic metabolism into anaerobic metabolism, and we're going to start seeing a rise in lactic acid, okay, which would lead to metabolic acidosis. This excessive clotting occurring within the microcirculation usually affects the kidneys and extremities, but it can also affect the lungs, brain, GI tract. Now, as soon as you have this excessive clotting, what's going to happen? Your fibrinolytic system is going to kick in. And so it's going to start breaking down this clot, this thrombus, okay? So the excessive clotting process in turn leads to you use up all your clotting factors. So you're going to have low levels of prothrombin, and you're going to have low levels of platelets. The thrombin circulating in the blood also activates the fibrinolytic system. So now that fibrin that looks like a spider web with the platelets, the thrombocyte, your platelets are called thrombocytes stuck in there, is going to get broke apart. So if you break apart a fibrin, it's called your fibrinogen split products or fibrinogen degradation products. So instead of this one little sticky spider web, it's going to break it into a million pieces, okay? Remember that, because now you're going to know what to look for when we look at the lab. So very concisely, your DIC is a paradox of profound bleeding because you started clotting and you used up all your clotting factors. So what are we going to see? Look for bleeding from or oozing around multiple sites, like around where you have an IV, in the gums, in the sclera of the eye, in the urine, changes in level of consciousness because they can bleed into their brain. You might see bluish discoloration of their fingers and their toes, dyspnea, oliguria, seizures, and complications would be that you hemorrhage and die, and you die from hemorrhagic shock, and you go into multi-organ dysfunction syndrome. Remember, guys, SIRS leads to MODS, multi-organ dysfunction syndrome, and you're not in MODS unless you have at least 2 organs that are dysfunctioning. So if I say that your BUN and creatinine are up and your urine output is down, that's not 2 organs. But if I also add that your albumin is low and your ammonia is elevated, now you see that your liver is failing. That is MODS. Back to DIC, please understand this. You need to know what the lab indicators are. My PT and my PTT, which talk about clotting, those are going to be elevated. And my bleeding time, it's going to take me longer, right, to clot. So those are all going to be up. And the broken parts of that spider web, my fibrinogen split products or my fibrinogen degradation products, are going to be elevated. All those are going to be up. And the most specific indicator of actual DIC is called a D-dimer, because it is a specific polymer that results when you break down that fibrin, okay, not just the fibrinogen. So your platelets and fibrinogen levels, those are going to be any of your clotting factors are going to be down because you've used them up. So platelets and fibrinogen levels are going to be down. Those are those raw materials that you use. You probably are going to see an increase in your BUN and your creatinine and a decrease in your EGFR, because this is going to affect your kidneys. Now, how do you treat it? Well, you got to figure out what's causing it. If it's septic shock, you need to get antibiotics into the patient. If it's trauma, you got to treat the trauma. But we're going to give them heparin. And this sounds counterintuitive because you're like, well, wait a minute, they're bleeding. But they're bleeding because they're clotting and they're using up all their clotting factors. So if I give heparin, remember, heparin is not a fibrinolytic. It's not going to break down clots. It prevents any further clotting from occurring, which will hopefully prevent DIC from continuing, okay? We have to administer specific agents necessary to replenish these clotting factors. So I'm going to look at my platelets. If I have thrombocytes less than 150, I'm giving platelets. Cryoprecipitate, that is specific for factor 8 and fibrinogen. FFP, fresh frozen plasma. Remember, blood, if I'm giving red blood cells, I'm not giving clotting factors. I have to give FFP and packed red blood cells to make sure that I have an adequate H&H in order to have enough hemoglobin cars on the train to get enough oxygen to the cells and CO2 away from the cells. Okay? Here were just some nursing diagnoses related to DIC, and you guys can kind of read that on your own. But one more time. What's going to be up? Your PT, PTT, fibrogen degradation products, your D-dimer, probably your BON and creatinine. What's going to be low? All of your raw materials for clotting. Your platelets are going to be low, and your fibrinogen levels are going to be low. Pam, is there anything you want to add to that?
Well, when you were talking about the chiroprecipitant factors,
Cryoprecipitate and factor 8.
they were saying in the book they don't, they're going to replace with those when the fibrinogen level is below 100. That might be important. I don't know.
That might be important. Good.
And you brought up heparin.
What, Pam?
You brought up giving heparin.
Mhm.
That was also an important factor.
Somebody else had a question out there?
I was just gonna present you a question from a student asking, will the D-dimer levels be increased in DIC?
Absolutely.
Yeah, did I not say that?
You did.
I think you probably did. I just.
Oh, like maybe they asked before. Yeah.
Yeah.
And honestly, guys, that is the most specific marker saying this person's in DIC because it's the breaking down of fibrin instead of fibrinogen. Great question. But I just started second guessing myself like, did I say that?
Yeah, just some questions previously in the chat. And another student, when you were talking about ARDS and SIRS, was wondering if those were caused by mods.
Okay, let's go backwards. Let's go backwards, guys. Let me get my screen share here. Okay, because this is confusing. I get it. I get it. All right. Remember, SIRS is simply systemic inflammatory response syndrome. Okay? SIRS, if you have sepsis, you have SIRS. Okay? But SIRS can also be from trauma and prolonged shock. Okay? So one of the #1 reasons for SIRS is sepsis, but it's not the only reason. Okay? SIRS then leads to MODS. And one of the first organs that we see affected are the lungs, and that's where acute respiratory distress syndrome comes in. The other very vascular organ is the kidneys, so we go into acute renal failure. Obviously, the brain, because it's full, it needs constant supply of oxygen and glucose, so we're going to see changes in level of consciousness. My liver, which we just talked about, is very important for making coagulation factors, making proteins like albumin that help hold fluid in the pipes through oncotic pressure, and it converts lactate into bicarb, keeping that 20-to-1 ratio so we don't go into acidosis. So SIRS leads to MODS, and you're not in MODS, multi-organ dysfunction syndrome, until you at least have 2 organs that are showing dysfunction. Does that help? The person that asked the question, feel free to talk to me, baby, talk to me.
Well, I was just wondering if like the bacteria, well, like the organ necrosis from MODS, is that causing DIC?
Oh, is the organ dysfunction
from
MODS
causing
DIC?
Yeah, because in the the review that you showed us before, it said organ necrosis could cause.
Yes,
DIC.
necrosis, absolutely. If you get to the point when you've gone from injury into infarct, dead tissue, absolutely, because your body is going to be inflamed more. And wherever we have pro-inflammation, we have pro-coagulation. So absolutely, yes.
Okay, thank you.
I understand what you're saying now. I'm sorry. Go ahead, Pam.
Your liver is important for your clotting factors.
Yep.
Correct?
Your
So
liver,
that would
liver
make
is
sense.
essential. Mhm.
If you had signs that your liver was failing, you could go into DIC and then go up to SIRS and another organ failed.
Mhm.
Another student was wondering if you can explain the passive leg raise.
Explain the,
Passive leg raise.
oh, passive leg raise. Yes. Okay. So what we want to know is if we've given enough fluid back to somebody who has lost fluid, like in hypovolemic shock. Okay. And so if they're hypotensive and we raise their legs, that can get like another 300 to 400, 500 mils back to their heart. If that indeed raises their blood pressure, then that was a positive response. So we will continue to give them more fluid. If I raise the legs and it does nothing to bring that blood pressure up, I know it's not a loss of fluid. Now I have to think I better give them a positive inotropic and a positive vasoconstrictor. Does that explain that?
Yes, thank you.
You're so welcome.
And Di, the relationship that last student, not with the positive leg raise, but the one about liver necrosis going to DIC, there's a figure in the book that talks about shocks, SIRS, MODS, and then it goes through each system failure. So sometimes
It's good to look at what's going to happen to each organ and how you will what are the clinical manifestations of when it's failing. Yeah, think about it. The kidney, I'm going to have decreased urine output, my BUN and creatinine are going up, and my EGFR is going down. Okay, the brain, changes in level of consciousness, not good, right?
ICP goes up.
Right, yeah, my heart, I'm going to have arrhythmias, my CBP and my wedge are going to go up.
Troponins.
Yeah, it could be my troponins and stuff going up, and I'm going to have decreased peripheral perfusion. My liver failing, that's when my ammonia is going to go up. My clotting factors are going to go down. My albumin's going to go down.
Liver function test will go up.
Yes, brilliant.
Yeah.
Yes, if my pancreas fails, my lipase, my amylase, my GI tract. Now, here's what's bad about shock. Remember, when we have prolonged decreased perfusion, our kidneys are going to do RAS. All right, they're going to secrete renin, and renin makes angiotensinogen from the liver become angiotensin 1, and angiotensin 1 from the liver is going to become angiotensin 2 in the lungs. And angiotensin 2 puts a major clamp down on the arteries, because if we have piss poor perfusion where we can't make urine, we've got to take perfusion that we do have and shunt it to the head, the brain, the heart, and the lungs. So this is a very potent vasoconstrictor. So I'm going to shunt blood away from my gut and my sex organs. That's one of the first things that happens in shock. So what happens in there is eventually I want to try to get my gut to work again. We're going to do PPIs and we're going to do that kind of stuff, but I want to try to get some enteral nutrition in there, because if not, the normal flora in the GI tract can now transmigrate through the leaky capillaries of the GI tract, and now I have sepsis. And that's bad. Okay, so what we do here now is angiotensin 2 has a second effect, and it makes us secrete aldosterone from the adrenal glands, which, if you forget, SALT, makes us increase sodium, and wherever sodium goes, we're going to have increased water. Okay, if this is hypovolemic shock, then yay, this is great. But if this is cardiogenic shock, boo, this is bad. That's why we're going to have to stop this, and we might have to give them ACE inhibitors, and we might have to give them beta blockers. Oh my goodness, I can't believe that just happened. I'm sorry, you guys. I was trying to get that off my screen. Go away. Oh, sorry. Okay, let me come back. Where did my screen share go now?
In the meantime, Pam, can you repeat what table you were referring to in the old book?
In the old book, it's as far as the progression or like a mind map, if you will. It was 67-1, figure 67-1.
Thank you.
Do most of you guys have the old book?
That's
Yeah.
what I saw in the
Yeah.
chat.
Looks like it. Okay, most of them. Sorry, I got the new one. I load my old one out. And then last thing that happens, guys, is the sympathetic nervous system. And that's where we start seeing epi and norepi being secreted. And that's why we see increased heart rate, increased force of contraction for a while. But remember, we don't have a continuous production of epi and norepi. That's why a lot of times in shock, we're giving these people that and dopamine and Dobitrex because we're running out of it. We only have so much of it. What else?
I don't have any current questions in the chat.
Okay. I know this is the Big Mac Daddy test, guys. But if you just kind of compare and contrast and wrap your mind around what are the basic, most important things about each shock and what are those clinical manifestations going to look like and what am I going to do to treat each kind of shock, you will be doing fine. You'll be doing fine. Okay. We talked about what ARDS is and how to prevent ventilatory associated pneumonias and how to take care of low pressure, high pressure alarms. I wouldn't spend a whole lot of time understanding the different ventilatory modes because you're not respiratory therapists and you're not critical care nurses. You're going to be novice generalists. Okay. Just know what are the bad effects from it. What should you monitor? We already talked about all that. As far as DIC, know about what all the labs are going to look like. Remember, you're going to try to, but I don't know if I mentioned petechiae. Petechiae are those little itty bitty, and purpura. They're the little itty bitty, tiny, purpley, reddish colored things that you should never see on somebody. That is a horrible sign. And whenever you see it, you got to think of DIC, petechiae.
I have some questions. One student was wondering if we could take a break for a few minutes, and then
Sure.
And then I have some questions. If we do take a break, I have some afterward.
Or why don't we do this? It's 2:11. How about if we come back at 2:20? Is that good?
Sounds good to me.
Thumbs up. The people I can see your pretty faces. We good? Okay. Come back at 2:20, and then we'll start with your questions, Eleni.
All
Thank
right.
you.
Come on, do you want to go potty? Come on.
Before we get back started again, for the students that haven't already put their name and student number in the chat, if you could do that, that would be great.
Yes, please, guys. We want to make sure that NIP gets credit for all this because it's a grant-funded program, and you know how much you love NIP. So please make sure you send your name and your ID number.
Thank you, Di.
Betcha, girl.
And for anyone wondering if this recording will be posted, it will be posted up to YouTube, and then we're going to post the recording from YouTube onto the NIP Commons.
Perfect. What was the next question, just so I can kind of get ready for it?
Oh, sure. Let me go through real quick. So we had a student wondering if there was a certain order that SIRS, sepsis, and MODS goes through.
Yeah, okay.
And then another student was wondering if you can go over PEEP again.
Sure. Okay. Sure.
Perfect.
You betcha.
If you have a chance, can you go over CPAP and BiPAP too?
Yeah, sure.
Thank you.
I'm going to go back to screen share here.
Alrighty. So I heard you say earlier that this was a big test. Is this the test that they take before the NCLEX or something?
No, this is just one of those tests that has a lot of meat, a lot of content. Yeah.
Gotcha.
But yeah, that's what I mean. Then they have another test, and then they have their final, and then they have what we call an end of program, where it's ATI, a testing that they have to get a level 2 or higher on in order to then be considered graduated, and then they can take their NCLEX.
Gotcha.
So Pam, I don't know, can you look in your book, please, the old book, and tell me where you find SIRS, because I find mine in chapter 66, shock, sepsis, and multi-organ dysfunction syndrome, because somebody was asking about the linear progression of SIRS to ARDS to MODS, that kind of thing. So I'm going to start with SIRS and understand, hopefully we can help you understand that just like we used to say, when you have an infection, you obviously have inflammation. Okay, but you can have inflammation for other reasons besides infection. So let me say that again. When you have an infection, you obviously have inflammation, but you can have inflammation from a bee sting. It's not an infection, okay? So SIRS, systemic inflammatory response, where you have inflammation in other parts of the body, right, where this insult never happened, that can occur for many reasons. But if you have sepsis, you already have SIRS, okay? So mine in this new book is page 1583. Pammy, where's yours?
I'm trying to look and see if it,
okay. When you find it, yell it out. But I'm just going to start here for time reasons. But systemic inflammatory response is a systemic inflammatory response to a variety of insults, including sepsis. It's just one of them. But anything, ischemia, infarction, injury, any dead tissue, causes generalized inflammation in organs remote from the initial insult. That is characteristic of SIRS. Many different mechanisms can trigger it. So it can be burn. In my situation, it was trauma, crush trauma. Could be from surgical procedures, abscesses. One of my friends had a pancreatic abscess that caused her to go into SIRS and then into MODS. You're always going to have SIRS before MODS, okay? Does that make sense? And if you have sepsis, you already have SIRS, okay? Just like if you have an infection, you already have inflammation. Okay, the real reason, one of the main reasons that sepsis leads to SIRS is because of that endotoxin I was telling you about that makes your pipes leaky, okay? Global perfusion deficit, so prolonged shock from any of these states. When I start slipping from aerobic metabolism into anaerobic metabolism and lactic acid starts building up, I'm in SIRS. SIRS will lead, so it's a systemic inflammatory response. And we already went through what you will see, temp up, temp down, all those things, those parameters, right? Now, multi-organ dysfunction is when you have 2 or more organ systems in an acutely ill patient where we see homeostasis cannot be maintained. MODS results from SIRS. These 2 syndromes represent the end of the continuum of shock. So transition from SIRS to MODS does not occur in a clear-cut manner. What I would encourage you to do is to back up and read through the stages of shock, because when you read through the stages of shock, you can kind of see where SIRS kicks in, okay? We have to catch the patient when they're in the initial stage, all right, when lactic acid is starting to build up, when they're starting to switch from aerobic to anaerobic, and then in the compensatory mechanism, when we start seeing the drop in the blood pressure and the heart rate going up. If we intervene there, we can bring them back. And if not, they're going to go into progressive shock, where their level of consciousness begins to fail worse. And the pulmonary system is probably the first to be affected. Now we're going from SIRS into ARDS. And the refractory is the late stage. We can't get those people back, okay? So one of the things in MODS is the ARDS, A-R-D-S, okay? So somebody asked me, I hope that clarifies SIRS into shock into, okay. If you have sepsis, you already have SIRS, but shock can lead to SIRS, which leads to MODS. Trauma can lead to SIRS, which leads to MODS.
Okay,
What else, Pammy? There's 1,000 other things that can cause SIRS, abscesses that can lead to MODS. But if you have sepsis, you definitely already have SIRS and you're heading to MODS. And one of the first organs that's going to be affected is your lungs, and that's where ARDS comes in. Somebody asked me about PEEP, correct? Is that what I heard, babe?
Yes, a student was wondering if you can go over PEEP one more time.
Oh yes, and then CPAP versus BiPAP. Okay. Let me start with CPAP and BiPAP first, because we always go less invasive to more invasive, right? So if somebody starts showing hypoxemia and they're struggling to breathe and oxygen itself is not helping, then we have to help the ventilatory process. Remember, CO2 is a much better indicator of ventilatory function because it's a easier diffusible gas. So if PaO2 starts dropping, that's one thing. But when I start CO2 rising, now I realize that diaphragm is getting weak and this person's on their way out. So you can put them on CPAP. Remember, you have either a nasal bridge or the full face mask. And CPAP is continuous positive airway pressure. So it's just like this. Like you're driving the car down the road at 45 miles an hour and you stick your head out and you go, oh, and that air just rushes in at you. That's CPAP, okay? And I can turn it up, I can turn it down, I can put FiO2 with it, I can, put oxygen in there to make sure that I'm helping that person breathe in more easily, get that oxygen down there. With BiPAP, I can actually dial in a tidal volume. I can help force a set amount of air to go in each time that person breathes, and I can add PEEP. By the way, we lose physiological PEEP when we intubate somebody because we have just overridden the glottis. So PEEP is positive end expiratory pressure. So in ARDS, remember, here's my alveoli, and here's my leaky capillary because the endotoxins, right, have made my capillaries start to leak. So all the blood that's normally in my river is now in the interstitial space and in my alveoli, flushing out my type 2 pneumocytes, so my surfactant. Remember, surfactant is that phospholipid that lines the alveoli. it helps keep them open at the end of expiration. Because guys, when you inspire, that's going to blow open your alveoli, but when you expire, you lose pressure and they will recoil. Okay, as long as they have surfactant in them, they will never go flat. Much like the first time you blow up a balloon, it's very hard to blow it up. But once you take it back down, it's never going to go flat because your spit is in there keeping it open. That's what surfactant is. When you have leaking pipes here because of SIRS, and now we're going into ARDS, we wash out the surfactant, and now my alveoli looks like a deflated balloon. So it doesn't matter how much hemoglobin's coming through here, I'm not getting oxygen onto my hemoglobin. Okay, that's acute respiratory distress syndrome. A PaO2 of less than 60, when I have an FiO2, a fraction of inspiratory oxygen set at 60 or greater, is the hallmark of not AIDS, ARDS, sorry.
I'm like,
Different disease process. Okay, so what I need to do is I need to blow these alveoli back open. So positive pressure is continuous pressure as you're inspiring. But think about it, I inspire, my alveoli blows open, but as I exhale, it can collapse really easily, okay? But if at the end of expiration, as I'm going, when that alveoli is collapsing, the vent goes and blows a little positive pressure down there, I can blow back open my alveoli. That's what PEEP does, okay? And it's a great thing. We try to keep it between 5 and 20 centimeters of water pressure. Otherwise, we cause baropressure. Realize if I'm blowing open an alveoli and I'm blowing it open and I'm blowing it open, I can just poof, blow it up. So that's one of the complications of PEEP is barotrauma, actually causing the alveoli to rupture, leading to pneumothorax, which could lead to tension pneumothorax. And let me just erase that really quick here. The other thing is that your heart, all right, here's your superior vena cava, your inferior vena cava, here are your lungs, please go back up there. Here's your trach and your bronchi, okay? And so if I am increasing the pressure in my lungs are going to have increased pressure, and that's going to start putting pressure against my superior and inferior vena cava, decreasing venous return to the heart, decreasing preload, decreasing stroke volume, decreasing cardiac output. So the big complications of PEEP are decreasing venous return to my heart, which leads to decreased preload, decreased stroke volume, decreased cardiac output, and potential barotrauma, where I actually blow up one of my lungs.
hey, Di,
Yes.
isn't the collapse of the alveolar sac called a bleb?
Well, okay, what happens is when you have multiple alveoli together, that's a bleb. And if that makes it more fragile, right? And if I just collapse like certain amounts of alveoli, that's atelectasis. If my lung, which has a protective covering around it, if my lung blows up and I get positive pressure into here, my lung is going to collapse. That's called a pneumothorax. Okay, that's the difference between a pneumothorax and atelectasis. And a bleb, like Pam was talking about, is the more fragile our alveoli become. They kind of become one big cluster of grapes instead of individual grapes, and they become more fragile and they're more easily susceptible to barotrauma. Okay, we got a few more minutes. What else?
I don't have any questions at the moment.
Okay, you guys can jump on and ask. You don't have to type it in.
So by definition, hypoxemia is the PaO2 of less than 90.
Isn't 80 to 100 normal? Okay, so wouldn't hypoxemia be less than 80?
Depending upon certain characteristics, right? A COPD may not ever really, but that's technical. Never mind.
Yeah. So your PaO2 should be between 80 and 100. I don't think that parameter has changed in this book. So a PaO2 of less than 80 is hypoxemia, which is low oxygen in the blood, which will lead to hypoxia, low oxygen in the cell.
Which is tissue perfusion.
And you know what? You just brought up a really good point. guys, remember, here's the end game here. We have to have adequate perfusion. We were created to have aerobic metabolism. If I have adequate cardiac function, I have adequate hemoglobin train, I have adequate fluid in my river, I'm going to have adequate perfusion, and I'm going to get oxygen in my cell, and my nucleus is going to be able to 36 to 42, it's going to make 42 ATP, which is adenosine triphosphate, which is the powerhouse of the cell. That breaks down into carbonic acid, H2CO3, which breaks down into bicarb, HCO3, which is your base, and CO2. And then that further breaks down into, wait a minute, I just said that backwards. Bicarb, I'm sorry. Let me just erase this a second. Eraser. Here. Get it off. Back to here, draw. Bicarb and hydrogen ions, guys, okay? And so you want to have 20 parts of your bicarb to every 1 part of your hydrogen ion. This will then break down into CO2, which I can breathe out, and water, which I can either reuse or get rid of in my kidneys. If I go and I have any problem with any one of those P's, the pump, the prime, the pipe, I'm going to go from aerobic to anaerobic, which is about 4 ATP molecules and a boatload of lactic acid. That is why we look at lactate levels when we're looking at shock. The higher the lactate levels, the worse the shock. We also, another thing that you might want to remember is that when you're looking at sepsis, procalcitonin, we don't know why, but it's a precursor to calcitonin, which puts tone in the bone, one of your parathyroid hormones. Procalcitonin is elevated when somebody is septic. We don't know if it's because of the release of the endotoxins. I've looked it up in a million places. Just know that elevated procalcitonin levels is indicative of sepsis. And higher lactate levels is looking at the progressive levels of shock. It's not a good sign. And remember, the liver is what's going to take lactate and convert it to bicarb and rid it out of the body. And so if the liver is one of the organs that's failing, this is going to be up, and that's a bad sign. Okay. Any other questions, guys? Any other content we need clarification on?
So far, I'm not seeing any questions in the chat.
Eleni, how many students did we have about?
Right. Well, we started with 39. Now we have 35.
Okay.
And actually, I did just have a student ask if we could do an example of metabolic with partial compensation.
Sure. Let's do it. Okay. So here's a patient who I have to write my normals, guys. Have to. It's just what we got to do. All right. Remember, 740 is perfect. Acid, alkaline, CO2.
22, 28. Oh, no.
No, 45 to 35. And then your bicarb, which is your metabolic, right, is 22 to 28 now in that book. Or I don't know if it's still 26. Don't ask me. They told me they changed it. Go by what's in your book, okay? So if you've had somebody who's been in a prolonged perfusion, piss poor perfusion state, they're going to go from aerobic to anaerobic, and they're going to start holding on to lactic acid. You need to have 20 parts bicarb to every part acid. So they're going to start showing changes. So let's say you see this 7.28 and 45 and 12 again. So we look at 7.28, we definitely see we have acid, and then we look at 45, and that is normal. And we look at the bicarb, which is 12, which is acid. So that is an acidosis. What matches it? My bicarb. So I have a metabolic acidosis. And at this point, there is no compensation because both my CO2 and bicarb are now out of range. But now that I have this high level of acid, my chemoreceptors are going to trigger my hypothalamus, which is going to say, hey, we need to get rid of that other acid in the body, which is CO2. So we need to breathe deeper and we need to breathe faster. So now we might see this guy, 7.33 50, and 12. Okay, 733, I'm still in acidosis. My CO2 is still up. I'm still there. That says, I'm sorry. Sorry. This is not what I meant to do. I went to go 30 here, not 50. Okay.
Makes sense.
Let me get my eraser. Hold on. Erase. Okay. Go back to here. So we have 733, a CO2 of 30, and still a bicarb of 12. So this is acid, but CO2 of 30 would be over there, right? Would be on this side. So this would be alkalosis, and a bicarb of 12 would be acidosis. So I go back up. I'm still in acidosis. What matches it? My bicarb. So it's still a metabolic acidosis. However, my CO2 and bicarb are out of range opposite, so I have some form of compensation. Well, there's only two forms. Either it did it so well that my pH is back to normal totally, which it's not, so this is just a partial. Now, this same patient, I just need my eraser for a second, guys, so I can have some room here. This same patient, let's go back over here.
So that might be a diabetic and ketoacidosis, correct? With
Absolutely.
respiration.
Or like these patients we're talking about, anybody in prolonged shock. They're not able to get rid of this lactate. So now we have a patient that's 7.37, 30, and 12. Okay. Well, 737 is perfectly normal, right? 30 would still be alkalosis, and 12 would still be acidosis. So what we need to do is bring down 740. We know that we have compensation, correct? Because my CO2 and my bicarb are out of range, and it's complete compensation because, or full, same thing, complete or full compensation, because my pH is back to normal. But when I compare my normal 737 pH, it would be over here, right? Still normal, but on the left side of perfection. So this was an acidosis. What matches with it? The bicarb. So this was a metabolic acidosis with full compensation. I hope taking it through partial to full helped you see that. Whoever asked that, did that help?
Yes.
Great. Anything else, guys?
I'm not seeing anything.
Feel free to jump on and just shout to us. I saw on the ADN Commons that you guys are having something tomorrow night, right, with your instructors. So if you do have any other questions, make sure you write them down. Didn't I see that? Something with Miss Anderson and Miss Ross and somebody else? Yeah? Okay. I didn't think I dreamed that, but I could have.
I think it's Wednesday.
Wednesday. Oh, tomorrow's Tuesday. Yes, I'm so screwed up on my days. So not
I
till
think
Wednesday.
it's Wednesday at 5, I think.
Yes, I think you're right. Brenda. Just be aware of that. And you can always shoot me an email, okay? And now Pam's back. You can shoot Pam an email. We're happy to help. We're both tutoring, but different times. I think I only have a couple slots left for tomorrow. I think I have a couple slots tomorrow, but you have to put in the request through NIP, and then Pam's just getting back involved. So it's probably going to not be in time before this test. So if you need to shoot us an email or what have you, and I can help you that way, I'm happy to. And remember, you can always ask your instructors. I know this is very difficult with you all doing a lot of Zoom and not being face-to-face. So we're trying to help you out best we can.
I have a question.
Sure, Edith.
Would you guys do last minute math problem like you guys did last exam? It really helped.
Last minute math problem. What did I do?
No, not you. It was NIP, but not you.
Is this one micrograms per kilogram per minute like dopamine?
No, last exam, I think it was like the night before the exam, they had like a last minute heparin calculation for us.
You know what, you can't, okay, I will ask Lisa. I don't know that that's
It
gonna
was
be.
her. It was her that did it. Yes, it was her.
Okay, then what you need to do is send her an email, but let me tell you this, Edith, if you go onto the ADN Commons,
Mhm.
and Lisa's trying to pull them all over, Ann Nyberger, who was brilliant in math, and myself, we did micrograms per kilogram per minute, we did heparin, we did all the critical care math, and that's
Okay.
all on the ADN Commons. If you scroll down to NIP, and then you look for videos and you look for math, they're all in there. So
Okay.
if Lisa's not able to do that, you can review that there. Or if there's a specific thing that you need to work on, you can ask you can ask one of us.
Thank you so much.
Absolutely. Just remember to set up your dimensional analysis, guys, and it will serve you well for the rest of your life. You know, even so many micrograms per kilogram per minute. If you set it up in dimensional analysis, you'll always get to the right answer. Any other questions as we're coming to close here? Edith, you didn't happen to have an example of one of the questions you want us to go over, do you?
No, I actually haven't looked at a math yet.
Okay.
Yeah. But I will get to it.
Okay.
Okay.
I just want to remind everyone one last time, if you guys didn't hear it over the break, if you guys can put your name and student number in the chat, that'd be great before we all go
Yeah,
out.
before we leave, please, so that NIP can get credit.
Right. And I actually had one of the other students asking about how to access the tutoring request sheet to get a one-on-one appointment. And I just, would like to say, if you want a one-on-one session, go to the NIP Commons and then go to course content, and you'll see a tab that says meet a tutor, and you click on that, and from there you can see the whole process of how you get a one-on-one session, as well as the tutoring sign-up sheet.
Yeah. Most of my tutoring days are Tuesday, Wednesdays. And then I just leave Mondays open here and there for workshops. Pam, do you know what your days are going to be yet? I usually do Tuesday 1 to 5 and Wednesday 10 to 1. That's usually where I am, unless I'm taking the day off. Pam, have you set any times up yet?
We're working on that, but from what I understand, it'll be Monday and Wednesdays.
Yours will be Monday and Wednesday. What we're trying to do is we're trying to be as available as we can to the most majority of you that we can.
And then really quick, I have a student wondering if you could again review the need for FFP and platelets and why.
Yes, absolutely. Okay, so remember when we're replacing, like in hemorrhagic shock, when we're replacing packed red blood cells, that's exactly what they are. They're just the red blood cells. They're the oxygen carrying capacity of the blood. The plasma, which is your river water, is what has the proteins in it, the clotting factors. When you give regular blood products, your regular packed red blood cells, you don't have any of those in there. Remember, the liver is what manufactures those. So after every couple units of blood, like packed red blood cells, you need to think about FFP, fresh frozen plasma, which has all your clotting factors except for factor VIII and von Willingham's. And that's what cryoprecipitate has, and it also has a little fibrinogen in it. So when they're looking at your PT, your PTT, and your bleeding time, and your thrombocytes, they can determine what exactly you need, okay? And if you go into DIC, you've used up all your clotting factors, so we're gonna have to replace them all. So that person's gonna get FFP, they're gonna get platelets, they're probably gonna get cryoprecipitate to replace factor VIII, von Willingham's, and your fibrinogen. Did that help?
Looks like it did.
All right. All right, we got like 10 minutes. Anybody?
That question I had for you, Di, about the hypoxemia.
Yeah.
It's in the chapter on shock, SIRS, and MODS
So
under
they,
acute interventions, and it's under respiratory. It says, quote unquote,
yes.
a PaO2 below 60.
Oh, 60. You
In the
said 90
absence-
before. You said 90 before. Okay.
Yeah. In the
So below-
absence of chronic lung disease,
Yes.
indicates hypoxemia.
Yeah. Very good. And realize even a PaO2 of less than 80 is low oxygen in the blood. So the normal is 80 to 100. Okay, we clarified that. Brilliant. Anybody else?
I'm not
I think-
seeing more questions.
What, Eleni?
I was just saying that I have not gotten any more questions at the moment.
Okay, I'm going to stay on for 2 more minutes. If we don't get any more questions, we're just going to call it a day. I know that this is a really stressful time, you guys. Give yourselves a little time to get out, walk, do something good for yourself, okay? Because your mind can only focus so much, and you've got to get rid of that excess stress, right? Make sure when you go into your test that you do some deep breathing exercises, do some prayer, some meditation, and look at each test question as just what's there. Don't think about, well, what if, or one time I remember this. No, just what it says. And each test question is going to tell you something. That's the scenario. That's where you're going to pick up. If they said this person had an MI, you're going to start thinking, okay, they're going to be thinking about cardiogenic shock. Or this patient had a spinal cord injury, you're going to start thinking, or this patient has a fever. Oh, septic shock. Start getting your brain tuned in. Then it's going to ask you, what is your priority action, or choose all below that are indicators of SIRS, whatever. Say what you know before you ever go look at the distractors, and then go, okay, C says that, and go back and read your question again and say, yes, C, that's it. And then just make sure that A, B, and D, there's not one higher priority, okay? What's going to keep them longer, keep them alive longer, and keep them from dying? That's the one that's the highest priority. Okay, and don't change your answers. Go, Pam.
Di, one thing,
Yeah.
I'm sorry, cardiac tamponade on assessment, muffled heart sounds?
Yes. And pulsus paradoxus, correct?
And which one is the one that gives like a widening? I'm on the wrong one. Never mind. Cardiac tamponade, muffled heart sounds.
Don't forget about that. And that would be one of the obstructive shocks.
Pam, can you repeat what page number you were just talking about?
I'm sorry, I have the 9th.
Uh-oh, you're kind of frozen on my computer.
Questions. Guys, great seeing you all. At least your names, most. For your next test, you guys will watch the video. It's Pam and I doing it from like a semester or so ago about renal and liver, and then we'll come together on that Wednesday and provide a question and answer for you. You're so welcome. Thank you for sending me that. All right, guys, have a great one. We'll be praying for you.
Thank you. Bye.
Bye, everybody. Bye, Pam. It went well.
Hey,
Thanks, Eleni.
Oh, you're welcome. My internet is being weird and I keep getting cut off, so I'm gonna go ahead and end this so I don't lose
Yes.
the recording.
Okay, babe. Bye.
Thanks for
Di, I'm
having
going
me.
to call you real quick.
Sure.
Bye, thank you.